Director of the University of Haifa's International Program in Public Health and Global Health Leadership, hosted, of course, by the American Society of the University of Haifa. Welcome back, Dr. Green, from your travels, and good to have you back with us.
Thank you.
Yeah, of course. So after a week of reinfections, paused vaccination trials, we of course have a lot to get through. But I'm actually going to start here in Israel. Yesterday, the country began easing restrictions following its month-long lockdown. Now, after mistakes made following the first reopening earlier in the year, how important is it that they do things differently this time around, and what should that entail?
Well, I'm going to actually do it into two parts. The first one is basically directly in an answer to what you asked me. I'm not sure to what extent we can call it mistakes, because we really are in some kind of bind. I mean, basically, until we have a vaccine, we're going to be in the situation where we're going to be trying to modify basically the outbreak and modify its spread so that we don't put too much pressure on the health services. And that means, in some senses, opening and closing. A lot of the things that are being done, although they sound good on paper, there is some lack of logic to some extent. And that's not just here, that's everywhere. And that's not because of us, it's because of the situation. This is a virus that'll spread. You don't need 100 people infected to start an outbreak. You need one person. Basically, anyone who is infected can infect another one, and then another one, and so on and so forth. And that's basically what happens. So what happens is that when you do open up, you've still got infections around. In other words, the virus hasn't been eliminated. It's just a matter of time when it can build up basically capacity and start spreading again. And then there's the question of how do you limit it. So in a sense, that's a kind of a, shall we say, less optimistic view, because we really are in a situation where it's very, very difficult to control a virus like this, as it would be if it was measles or anything else. If we don't have a vaccine, it's extraordinarily difficult to control viruses that spread as easily as this one does. The other issue is, and also, I don't know whether we can say it's a not too optimistic one, is that I have a feeling that the surge that we're seeing in Europe and here is following a certain pattern. And the pattern, and what we pretty much had a fairly early increase in cases, not a huge amount, but we had an early increase. We did a lockdown or a lockdown, it stopped. And then we stopped for a while, and then around about June, July, we started seeing things going up again, and then much more in August. And it's related to all kinds of things, schools and to opening gatherings and all the rest. And then you see it in Europe, and I don't think it's coincidental. I think, when we're speaking about the waves and people, these kind of epidemics tend to come in waves for various reasons, partly because we introduce restrictions, and partly because there is a way, I guess, of the virus, building up capacity and steam. So I have a feeling that we really are seeing that second wave in Israel. And if you look at the graph, you could even say that there was a second and third wave.
Right.
And the unfortunate thing, in a sense, is that is just the sort of promo to the third wave, which comes in winter. And I think what you're seeing in Europe now, the kind of October wave which you're seeing now, is again a prelim to what you're going to see in the winter, unless you lock down, because in winter things are much more difficult to control, and then you have a really big wave which will go into like December, January, whatever. So in a sense, it's not unexpected. And I mean, unfortunately. So you would again go back to the question, well, what do you do? Probably just this up and down, close down, open up, close down, open up, until we have a vaccine. There really doesn't seem to be any other alternative other than to have a vaccine. We can come back to this when you want to talk about the vaccines.
Yeah, no, I assume that anyone thinking that we're over the second wave over here in Israel would be mistaken.
Right.
Now, going to move on to something that we did see in the news quite a bit last week. We had two high-profile late-stage clinical trials in Johnson & Johnson and Eli Lilly, and they were put on pause because of possible safety concerns. Now, just earlier in the month, AstraZeneca, so their vaccine trial was paused after two volunteers became seriously ill. So how much of a setback is this for, I guess, vaccine development in general, and how concerned, on a personal level, should we be too?
Well, first of all, let's distinguish that the two trials now, Johnson and Johnson, and I think the other one was what was the other one? Johnson and Johnson.
Eli Lilly it was.
Eli Lilly were treatment trials. They were not vaccine trials. So, and there you're actually giving medication to sick people, and that's a somewhat different area where you're likely to see side effects because you really are giving basically a medication, although it's maybe monoclonal antibodies or whatever, but or plasma and immune globulin. But this is, you're actually injecting something with the aim of treating, and it's not entirely unusual to have side effects. So they're still working on what are the optimal doses, and you're basically treating sick people. I think we also need to remember that in these trials, they are extraordinarily well monitored. And if there's any sign of something unusual, they stop the trials. That doesn't mean that the medication or whatever they're giving is bad. It just means that they are being extra cautious. And, I've been in a situation, and in fact, it can cause some problems where there was some apparent side effects, and I was one of the people who said stop immediately, and they stopped, and it was not related in any way to the vaccine at the time, and it was quite difficult to start it up again because people said, oh, but you stopped the trial, so it must have been serious. And you have to explain, or you stopped the trial because you were being extra cautious, not because it was really serious. So, that's the way the trials are designed. They have a monitoring board which monitors side effects. And if they have any feeling that the data indicates there may be some kind of problem, their job is to stop the trial, take a break, look at what's going on, and then decide to start again. So I guess that's probably what's been happening there. And also the trial with the AstraZeneca, one with Oxford, I think the Oxford group. Also, I'm not sure, sometimes I'm not even sure. My impression was that the side effect was not that serious, but even if it was, I don't think it was really established that it was related to the vaccine. And this is another thing you do. What you do is you stop the trial, and then you categorize the side effect. And you say, was it definitely due to the vaccine, possibly, probably, and so on. And most of them are ruled that they're unlikely. Right. In other words, they happened incidentally at the time that you gave it. And if you can think about it, people get sick, people have all kinds of problems unrelated to whatever else happens to them. You put a lot of people together, you inject things, and by chance, one or two of them will have this. So you're really working on this fine line where you have to make sure that you're not seeing real side effects. And on the other hand, you're not just identifying false alarms. So that's really the main issue there. My impression from the results that we're hearing about is that there's good progress with the vaccines.
Right.
However, it's going to be a long road. In other words, the vaccines are not going to become available very quickly and will not be available in big quantities. We still have to learn to what extent they'll be effective. In other words, do they really prevent the disease, and for how long, and for how many doses? So, and some of them are already planned to be given in 2 doses. So if you can imagine the whole scheduling problem and dosing problem and logistics, that's going to take certainly a number of months. And at the time, once that's started, though, you will certainly at least have the situation partly under control, because you'll have something then that you can use, and it will take time, but you can build up capacity in this way. So I think that's the future. That's what we're going to be seeing.
Right, and you actually started speaking about something I was going to ask in my next question. Let's assume we aren't a long way off having a vaccine. How will it be distributed? Who is going to pay for administration of the vaccine? and how will we ensure that scarce supplies will be allocated to those who need it most?
Yeah, there's been progress now, at least to some extent, with the WHO is coordinating trying to get the manufacturers also together so that there's what we were told equitable distribution, that low-income countries will not be left with nothing and so on. It's not going to be easy, because a country who's producing their own vaccine is going to be probably problematic in giving away some of their vaccine when they may feel they may not have enough for their own population.
Right.
So there's going to be tension in that area, and there's also going to be tension in the cost. So it's going to have to be a lot of goodwill and a lot of working together with the Gavi group, the vaccine group, with the Gates Foundation. They'll all be hopefully working together, and hopefully looking for best ways of doing it. The other issue that you raised is, who do you vaccinate? And interestingly enough, there is an idea of, for influenza, for vaccinating first children. In other words, don't vaccinate the high risk, actually vaccinate children at first. Although in influenza, the very small children are at risk, but not the elderly, because the children really do spread it to the adults. Right. And that's so that may be a good policy. I'm one of those who believes that could be a good policy also for the COVID vaccine. Partly because, although I know that the kids seem to be spreading it less effectively than in adults, they have less virus excretion and so on, they get less sick and so on. But I think that's when we'll actually be able to start getting kids to school. In other words, if you decide that the first thing we do is vaccinate, let's say, the under 6,
right,
and then they can go back to preschool and so on. That already relieves the parents who are now not able to go to work because they have their little kids at home. So it has two effects. It reduces to some extent that pool, and then go on. On the other hand, there are other groups who are waiting for the vaccine, healthcare workers. So I would put them at a high category, not because I'm in it, I'm not anyway working in a hospital, but I'd certainly, my colleagues who are there, in order to feel that, for them to feel comfortable under their kind of conditions, certainly they would be a high priority group. And then people in care homes who, not just because of their age, but because of the concentration. The one problem with people in care homes is that they are elderly and they have chronic conditions often. And those are the people who don't respond that well to the vaccine, not because of side effects, but they don't get the same kind of immune response. So the vaccine may not be that effective actually in the group that we wanted to be effective. But I guess I would pretty much put these people in the front. I would give little kids, I would give healthcare workers, and I would give care homes. And then, other people who are necessary in the workforce and so on. Each country has to really put together a list of the priority groups that will get the vaccine. But it's not going to be that easy. I mean, right. I just, to give you a curiosity, that's the last thing. I happened to be visiting someone in hospital yesterday, and there was a station there where they were vaccinating the people, the workers in the hospital, against flu. And I asked them whether I could get a shot, and they said, no, this is reserved only for workers in the hospital. So, right. And they were quite right, of course. Yeah. What I'm saying is that we're going to have that situation.
Right. Man, far from easy. So, another thing in the news, it's a busy week. After confirmed reinfections, both in Israel and America this past week, the question I guess everyone's asking is can you get infected with COVID-19 twice? I.e., after recovering from it the first time, can you then transmit it once again? And if so, does that actually render any vaccination ineffective?
There are a couple of questions there about the mechanism. First of all, can you get the disease again? There are diseases that you can get more than once, and we know it from the common cold, some of which are corona, where it does seem maybe just because you don't develop enough immunity, and maybe also because there may be some mutation in the virus, because these are RNA viruses and they can make changes. Fortunately, the COVID-19, the SARS, CoV-2 doesn't really mutate very easily. So that's an advantage. It doesn't seem to change its antigens, its response to vaccines, basically. So in that sense, if you have the disease, the chances of getting it for a second time are probably very low, but it does seem from the indication now that there does seem to be a number of people who appear to have been reinfected, because you can actually trace genetically the virus. They were infected by the same SARS virus, but slightly different. So it means it wasn't just a reactivation of their illness, because that's also a possibility, that you got the virus, you got sick, you got better, but the virus was still hanging around in your body. And there are viruses who do that. And in an extreme sense, the chickenpox virus will stay for you for years. So, and that causes shingles later. So that could happen as a possibility, and that's being carefully monitored. The question here then is, at the moment, it does seem in any event that you're getting pretty good immunity if you got sick from it. That's what it seems. For how long, we still don't know, because we're still only a few months into the pandemic. For the vaccine, interestingly enough, there are a couple of vaccines that are better at protecting you than the actual disease. So that's a possibility. Like the HPV vaccine, I think, is considered to be more effective in protecting you than the disease itself. And there may be several others. So it's not impossible that the vaccine, in a sense, will be more protective than the actual disease. So that's a possibility. And we're hoping that's also going to be the case. So I think that's it. But you're right, this is being very carefully monitored. And it puts another factor into dealing with a really complex situation.
That's correct. That's right.
And also, that'll add the fact that maybe we'll need to be vaccinated every year. Right. Which is bad news for the public and good news for the companies who make the vaccine. That's right. That's good business.
That's right. Great. So, look, I want to get on to something that's quite exciting. We've explained in the past how you were one of the university's 18 faculty members to be awarded funding from the Israeli Ministry of Science and Technology to draft COVID-related research proposals. So I myself have been eagerly trying to follow this, and I understand that you do have some updates with us.
Yeah, I'm a little bit embarrassed by the fact that our second survey was delayed, and it's actually in the field right now because of the holidays, and there were some technical things with the questionnaire and so on. So now we are currently conducting a survey of 800 people, or maybe 1,000 people, looking at different aspects of the use of health services during the pandemic, and also looking at other features about how they feel. And also we are specifically also looking at how people feel about actually receiving the vaccine. So I can tell you, and I've told you, we have our first survey, which we're now actually putting into a report, where there's indications that a significant percentage of the population, maybe 20% or more, would not have the vaccine. Certainly, well, put it this way, maybe only 20 to 30% would actually be prepared to receive a vaccine in the early stages. They would wait to see other people. And there'd also be a not insignificant percentage who would refuse to get the vaccine at all because they are concerned about a new vaccine. So that's going to be an issue that we're going to have to deal with, as to what do you do about people, not just, we've got a vaccine, but people don't take the vaccine. And vaccines are particularly problematical in the sense that every vaccine, when you give it on a mass scale, will actually result in a few people complaining about something. Some of it related to the vaccine, a lot of it not related to the vaccine. And obviously, any report like that in a vaccine that's being produced at this speed will create concern. And I think I even mentioned to you last time, there is a possibility you give the vaccine to 100,000 people. And of those 100,000 people, even one or two of them have serious side effects. They get very ill. But you don't know if it's related to the vaccine at all. You're not sure. But people will then put one and one together, or whichever you want to look at it, and say, new vaccine, hasn't been tested for long, was produced in unusually rapid circumstances, that's a problem. That worries me. So I would say that that's going to be an issue, which is going to be something you're going to deal with. And you may well find the stop and start there. They'll start giving the vaccine, and then there'll be a report of some side effects, and then people will stop taking the vaccine, and then you have to try and encourage them to come back in again, and so on and so forth.
And you'd expect the media to play a big role in reporting on that and explaining the travesties that are associated with that too, I would imagine.
Vaccines, though, have an incredibly safe history, unlike what people think. Very much safer than any of the medications we use, because it's a different process. So, you very rarely get bad effects of vaccine.
Right.
That doesn't mean, and I'll say it again, I think I've said it before, I'm very happy to sign up for the vaccine trials. I'm prepared to be the first in to get the vaccine, because I know that it's gone through a very strict safety procedure early on. So I don't have a concern about that. And I think that that's something also that the public should understand.
Yeah, reassuring to hear from someone like yourself, absolutely.
Right, but it's an issue so that's one of the issues. There are a number of others that I spoke about. I'll maybe just mention a couple of them. We find that about 30% of the people who needed health care, in other words, they really needed help, but did not go to the hospital or did not seek or the clinic. They didn't go because they were afraid of COVID. What is that impact going to be? We're not clear. Some of them reported more about their family members saying that in their opinion, they were actually harmed by this. Obviously, this is self-reported. We also find a small but relatively significant percentage who did not take their kids to be vaccinated against other diseases, measles, mumps, rubella, and so on. That's going to be a major problem. And maybe I'll just mention that very quickly. I'm head of the committee in the Ministry of Health for monitoring measles and rubella vaccine in terms of trying to eliminate the disease. And this is a vaccine we report to the World Health Organization. If our vaccine numbers, in other words, the percent being vaccinated drops to below around about 95%, we're in trouble. In other words, it has to be very high. So even if 10% don't get vaccinated, we could well be facing another measles outbreak or rubella or whatever. So we hope that's not going to happen.
Absolutely. Well, thank you for sharing those results, Dr. Green. But one thing, running short on time, but I want to make sure we get to, yesterday also marked an important date for the university. I know that with the start of the new academic year, I know that your public health program starts today. So I just wanted to get a little inside information from yourself, first of all, on how that's been going and how the students enrolled in the university's program are doing as well.
Okay, so let me just mention that we're in the School of Public Health, which is a very big School of Public Health. We have registered, I guess, 500 or 600 students, and we have a cohort coming in that's over 200, who are all graduate students doing masters and so on. But we have this very select international program, which was started 5 years ago. This is our 6th year, and it's not an easy. It's a program where people pay fees. In other words, it's not subsidized, and they're paying to come and study in Israel in this program. It's run in English and it's accredited in the United States. We have this year the highest we've had ever. That's 21 students, all excellent from 7 countries. Sometimes we have from 10 or 11 up to now. We've had from about 25 countries. And out of those 21 students, 17 are already in Israel. In other words, even with the lockdown, they are here. And the other 4 are planning to come. In other words, they are delaying it for a few months with our permission. But we are very impressed by the fact that when I really impressed, I was so impressed with how hard they worked to get here. In other words, they did everything they could to get a visa, to get in time. It was amazing. And they here, some of them are at the dorms, an incredible group. I think one day we need to have one session here. We have all the students on the session, 21. We'll come into the classroom, maybe.
Yeah.
Great group, an excellent group of students. Some of them from variety of backgrounds, but really high academic. I would say the average academic level in that program is higher than the total School of Public. I'm sure of it. They really are very well qualified students.
Amazing. And that's
So
really great to hear.
we're
Really
pleased
great.
to get any more support because we really want to get more from low-income countries. And 3 were turned down from Africa because we couldn't support them. Good students, 1 a physician and 2 others, but we didn't have money to support them. So always it's very helpful if we can bring more low-income students into our programs. That's a little bit of advertising, but it's an important mission. We really see this as an important mission.
Absolutely, absolutely, and couldn't agree more. I think all of us here are trying to do our best to ensure that not only people from low income regions in
Yeah.
Israel but all around the world are still able to get access to education. So thank you very much for giving
Thanks,
us.
James.
Unfortunately, that is all we have time for today.
Right.
Dr. Green, thank you so much for
Pleasure.
speaking with us as always. And as always, finding a way to help us navigate through the pandemic. Thank you also for sharing your own research with us.
I'll give you more next time, I promise you, because we just
well, we
finished the survey now.
we look forward to that. It really is. It's absolutely fascinating to hear about it from an inside perspective. And as always, if you do have any questions for Dr. Green, any of you out there, please do leave them in the comment section of this video or email them to info@asuh.org. And for more information on the university's work and around the pandemic, and to show your support to the university during this time, as Dr. Green just mentioned there, please find a link included in this post too. Thank you all for tuning in, and please stay safe.
Thanks, Jay.